Good evening and thank you everyone for joining us today. I, Amit Saxena, along with my colleague Dr. Deepika Chabra from Medical Services and Mr. Vinod Upadhyay, Zonal Manager, Jagsonpal Pharmaceuticals, are pleased to welcome you all to this scientific Sangam organized by ISOPARB Prayagraj in association with Lucknow and Allahabad Obs and Gynae Societies, with academic partner Jagsonpal Pharma Ltd, makers of DIVATRONE 10 milligram tablet, Dydrogesterone. We thank you for this opportunity to connect with you today through this webinar and proud to present DIVATRONE 10 milligram tablet, fully indigenized micronized dydrogesterone, the only brand having 36 months of shelf life. We also present injection maintain 500 and 250 milligram hydroxyprogesterone caproate, helps maintain normal pregnancy till term, and Lycorate Prex sachet contain L-arginine, lycopene, and DHA. We would like to express our gratitude and warm and hearty welcome to extreme experts and attendees. We kindly request you to post your questions, explanations, suggestions via text in Q&A box or chat box. This webinar is streaming live on Facebook and the link is already shared on the circulation in the chat. We'll be sharing the YouTube link for you to watch in future. Now I request Dr. Ranjana Khanna Madam, Founder President ISOPARB Prayagraj, Vice President FOGSI 2017, ICOG Governing Council member, to kindly take the proceedings further.
A very good evening and a very warm welcome to everyone. At the outset, with folded hands, I will first pray to Lord Shiva before we start the proceedings. So a very warm welcome. I have the proud privilege today to invite my very, very dear friend, Dr. Madhuri Patel, who is the super dynamic Secretary General of FOGSI. Madhuri, I have known you since so many years and found you extremely hardworking and very dynamic. And we are all a witness to your dynamism as of late. And of course, I want to welcome our senior teachers like Dr. Manju Shukla, Dr. Manju Verma, who have been the ex-presidents of UPCOG, and the dynamic speakers, Dr. Muralidhar Pai, Dr. SP Jaiswar, and of course, our president of Allahabad Society, Dr. Lalita Shukla, president-elect Dr. Shubha Pandey, and last but not the least, our very dynamic secretary of ISOPARB Prayagraj, Dr. Amita Tripathi, and the convener of this program. And we also have with us the secretary of the Lucknow OBGYN Society. So without much ado, first I would like to introduce our chief guest of the program, Dr. Madhuri Patel. She is Secretary General of FOGSI. She was Joint Secretary FOGSI 2009. You know, Madhuri, I came to know about this time in the ICOG convocation when you talked about in the ICOG when changeover, when Lakshmi became the chairman. So then I came to know that you were the joint secretary when Dr. C.N. Purandare was the president of FOGSI. That is when you told us about it. So she was joint secretary FOGSI way back in 2009. So many years she's been associated with FOGSI. Former committee member, FIGO preterm birth, associate editor, Journal of Obs and Gynae, Jogi, honorary clinical associate, N. Wadia Hospital, Parel, Mumbai, honorary consultant, Police Hospital, visiting consultant, St. Elizabeth and Messina Hospitals, former professor in HOD OBGYN, MGMH, Mumbai, former associate professor, GMC, Mumbai, awarded the MOGS, Mrs. Shelja and Mr. Narayan Pandit Award for the year 2019-2020, delivered guest lectures, of course, innumerable, national and international levels, And we know your capabilities, Dr. Madhuri, and I welcome you once again to please give a few words of blessings for my program.
Dr. Ranjana, it is so nice of you. Thank you for your warm and generous words. I must talk about Ranjana that I have found one of the best friends when she became VP and I was, I think, Deputy Secretary General.
Yes.
And we since then we are very thick friends. And our wavelength, whatever we say, it matches. So just now Ranjana told me, Madhuri, you have to join. I say, Arey, I'm in the conference and I'm leaving because AICC ICOG conference is happening in Mumbai. So I was there for the inaugural function and tomorrow I have a talk. So I said, let me start. Then I started and I cannot dismiss Ranjana because she is my very dear friend. So Ranjana, I'm so happy for you and you are doing a great work with your team. So I can see Dr. Verma, Dr. Manju Shukla, of course. They are our senior. Then Dr. Jaiswar, we had together at Colombo, and of course your Amita and your secretary of ISOPARB and all, and the Lucknow and the Allahabad Society. They are doing the great job, and you have excellent speakers today. I must tell you that a maternal mortality about 3 decades, that is 30 years back, it was 600 plus in our India. And with governments, all these programs like NRHM, then Janni Suraksha, Janni Sisu Suraksha, then now maternal death surveillance and response, all these programs, there were institutional deliveries more and more happening. So the maternal mortality and people, we are working at a grassroots level. I must appreciate government is doing their duties. We should appreciate that. But you people are working at a grassroots level and you have come and you have helped our India to bring down the maternal mortality rate to 103 today per thousand live birth. So that is very significant. Even globally, they could not reduce, but India could reduce very fast compared to globally.
Yeah.
So everybody is appreciating because in FOGSI we have so many programs are happening about the maternal health and the newborn, perinatal. There are so many, and we are training. We have Manyata in the FOGSI, where we are doing a 16, WHO checklist program, and we are training not only doctors, but we are also training paramedicals. Because what I observe, when we are paramedical staff in your nursing home, if they don't realize that there is something wrong, they don't inform the doctor till that time. So your paramedical people also should be trained. So we have a very good Manyata program. Then we have many projects, especially for postpartum hemorrhage with FIGO, and there are state level also in Lucknow. So we are doing very good, PPH, program. And then there are so many programs are happening. Projects are coming to FOXY, and we all are diverting these projects toward the high mortality rate. You know states like Jharkhand,
True,
and
true.
Assam and all. So
Mm.
now we are really happy. Now there are some states, they've achieved the maternal mortality reduction, rate to less than, 34 and 45. Maharashtra we are at 45, Kerala is 29, Andhra
Wow.
Pradesh, and they all have gone below 70. So this is not only one person work, but this is all of us are doing work, and that is really
True.
helping our mothers. So I'm really, really happy you've taken the topic as a hypertensive disorder in pregnancy. And everybody must have heard that inverted, pyramid for the antenatal care. What we used to start in a third trimester screening, now we have started with the preconception and the first trimester. And we can predict so many things, similarly hypertensive disorder
Mm.
also. So first common maternal mortality, the highest is for PPH and second is PI. So if we can, both the things we can look after properly, then our maternal mortality rate of India is going to come down to less than 70 per 100,000 live births, by 2030. And maybe we may achieve in 2025 also because we are all working towards it. So I must, say that whatever, Ranjana, you are doing, I'm congratulating you and your team for the
Thank you.
excellent, this webinar. And these are all learning phase. Even I go to the maternal death surveillance, response meeting at Mumbai district in Mumbai, and I represent FOGSI, and I have realized that sometimes the obstetric, you unpredictable. Even the low risk patient can, die.
Really, really.
So, it is very disheartening when I hear these cases, young mothers, young, they are losing, mother is lost, mother-in-law is lost, I mean, the daughter-in-law is lost, daughter is lost, wife is lost, child is motherless. So, these are the things we are really progressing to reduce the maternal mortality rate. So, Ranjana, you have selected the speakers also, chairpersons also excellent, and they are definitely going to do justice to the topic, and we will all learn, you know. And I wish all of you the best of luck. And at the end, I always like to quote Nelson Mandela, that education is the best weapon. When we use, we can change the world. So, dear friends,
Right,
let
right.
us use this weapon of education. Let us update our knowledge and give best to our women to achieve our goal of SDG, less than MMR less than 70 per 100,000 life birth. Ranjana and team, I am really thankful to you for inviting me and making me feel very very happy, and thank you very much.
Thank you so much, Dr. Madhuri, and thank you for, despite all your busy commitments, still you managed to make it. Thank you so much for this.
Anytime for you all, anytime.
Thank you so much, Madhuri.
Thank
Thanks a
you.
lot.
Thank
Now I would like to request Dr. Amita Tripathi to take the proceeding forward. She is the very, very super dynamic secretary of ISOPARB Prayagraj. And we had this AOGS OBDIL conference, Obstetric Dilemmas, and she was the organizing secretary in that. So, Amita, I would like you to please take the proceedings forward.
Thank you, Ranjana ma'am. So a very good evening and a very warm welcome from my side to our chief guest, to our esteemed faculty and the delegates to this webinar. Today's topic of the webinar is one of the most dreaded and ever-changing complication of the pregnancy, that is hypertensive disorder of pregnancy. Despite lots of researchers, we are still have many doubts. So to clear these doubts, we have prepared for this webinar. And without wasting any time, we would like to start with our first session, which is the prediction and prevention of preeclampsia. And the speaker is none other than President of Lucknow OBGYN Society and President of Lucknow ISOPARB, Professor S.P. Jaiswar ma'am. And to chair the session, we have Dr. Manju Shukla ma'am. She is one of the most loved gynecologists of the, I can say, of whole Uttar Pradesh. She has been professor and head of department in KGMU Lucknow, president UPCOG, president Lucknow OBGYN Society, and chief editor general of UPCOG. She has been master trainer of contraceptive technology by JPICO, master trainer EMOC, master trainer in maternal health, and trained and Lakshya Kayakalp and RHM. Welcome, ma'am. Our next chairperson is Dr. Shubha Pandey, ma'am. She is head of department obstetrics and gynae at very prestigious Kamala Nehru Memorial Hospital, Prayagraj. As Dr. Ranjana has told that she is president-elect of Allahabad OBGYN Society. Congratulations and welcome, ma'am. Ma'am is teacher and trainer of DNB and DGO students. Welcome, ma'am. With this, I request Dr. Shubha Pandey to kindly introduce our speaker, Dr. S.P. Jaiswar, ma'am. Dr. Shubha Pandey, ma'am. Over to you.
Thank you, Amita. Good evening, everybody. Dr. Jaiswar is my esteemed colleague from MLN Medical College, Allahabad. At present, she is professor and head of department Obstetrics and Gynae, KGMU, Lucknow. She has many awards and fellowships to her credit. DM Sharma and Madhu Sharma Award 2019, Gold Medal in Video Presentation 2018, Dr. Kutti Oration Award 2017, and Dr. Mrs. Chandravati Prize Award 2017, Narchi Fest Award, Eminence and Research Award, and many other social awards by the Chief Minister and Governor of UP. She is President LOGS and President ISOPARB Lucknow currently, and has been Vice President and Secretary too.
At the outset, thanks to you, Ranjana ji, Amita ji, and pranam to my guru, Manju ji, Manju Verma madam, and Manju Shukla also, along with my seniors. There are so many seniors also. And really, you have chosen this topic very well, because today we are receiving so many patients of preeclampsia, eclampsia, and even they comes in the pulmonary with an pulmonary edema, and it's difficult to say. So really, this topic is very good, and I think we have to work more on this. So my topic, which is depends on the prediction and prevention of preeclampsia. Why we bother so much? As we know, the preeclampsia kills one woman in every 7 minutes. So till I am completing my talk, I think more than 2 women will die due to this preeclampsia and eclampsia complication. So about the incidence, if we go for the incidence, the WHO estimates globally up to 70,000 maternal death and 500,000 infants death. And the worldwide preeclampsia incidence is 5 to 10%. So this is responsible for 16% of maternal deaths, 20% of neonatal intensive admission, and 6% even the patient affects in the postpartum period, and 3 to 5 times higher end stage renal damage as compared to the normal pregnancy. So but there is a new definition has come about the preterm preeclampsia. When it occurs less than 37 weeks is called the preterm preeclampsia. Early preterm when there's a less than 34 weeks. Late preeclampsia when more than 34 weeks, and term when there is a more than 37 weeks. So our aim to cover this preterm preeclampsia and early preterm preeclampsia. So in this, if we go for the pathophysiology, we see that the preterm preeclampsia is having strong association with the defective placentation, while the term preeclampsia is more affected by the maternal factors. If you go for the physiology, we know the placenta, when the placentation starts, the physiology starts from there. So there are lots of factors like the genetic factors, environmental factor, immunological factor, metabolic factors. They are all responsible for abnormal trophoblastic invasion and differentiation, ultimately leads to the placental ischemia and hypoxia. And there is a disbalance between the placental growth factors and between the SFT. These are the one is the angiogenic, one is the anti-angiogenic. This is our imbalance is responsible for this changes. So ultimately it gives changes in the present, which is present as a hypertension, proteinuria, edema. There may be hepatic ischemia, active coagulation system, activate the coagulation system, means ultimately it affects the all system, even with the, it is responsible for the cerebral edema. So it has been divided into stage 1 and stage 2. So prediction is very important. Question has arise whether we screen every patient or we use selective. So for that, the universal screening is must. So for next question, how to screen? Because we know in our country, the patient don't come at early stage many times. So catching the preeclampsia in early stage is still challenging. And even if she comes late, it is very difficult to make out which patient will develop convulsion or eclampsia. So the opportunity is there. Once she comes at early pregnancy, we can catch there and investigate for at early stage in the first trimester to identify the preeclampsia, and we have to identify the risk factor. Even if she comes in the late, again there is some investigation or some mode of predicting the preeclampsia. So depending on when the patient comes, if the patient comes in the first trimester, then we can use traditional approach. Traditional approach is still, it is quite good for especially in our country when there are lots There's sometimes we don't have facility at periphery, for that still it is beneficial. So in this includes the demographic characteristic, medical history, especially maternal history, by which you can make out which patient is a high risk to develop preeclampsia. So this is the long list given by the NICE guideline as well as the ACOG guideline. NICE guideline is divided into major risk factors and moderate risk factor. While the ACOG committee opinion is in 2018, they have divided into high risk factor and moderate risk factor. In high risk factors includes the history of preeclampsia, multifetal gestation, autoimmune disease, type 1 to 2 diabetes, chronic hypertension, or renal disease. And the moderate risk factors include first pregnancy, maternal age is more than 35, BMI more than 30, family history of preeclampsia, socio-demographic characteristic like African American races are low, are more prone, even the low socio-economic status are also, and the personal history is also important. So women should be considered to be at high risk of developing preeclampsia if they have any one high risk factor or any two moderate risk factors. So many times by history we can pick up which patient is more prone to develop preeclampsia later on. So the traditional approach is still very good along with the demographic and medical history. The advantage is that it can apply on every patient, all pregnant women without any cost and without any additional testing. Disadvantage is that it has poor sensitivity, only it predicts in the 45% of cases according to guidelines. So the research is to be focused to find out the better marker by which we can detect the defective placentation. So these are the markers, can be divided into biomarker, into the biophysical and biochemical. The biophysical markers are mean arterial blood pressure and mean uterine artery pulsatile index, while the biochemical markers are serum placental growth factor and serum soluble FMS like tyrosine kinase, SFLT. These are the two important biochemical markers. So according to Fetal Medicine and Medicine Foundation, we can predict the preeclampsia by maternal characteristic, medical obstetric history about the risk. But if we add this biomarker, we can modify the prior risk also. So for this, these are the triple test for the preeclampsia detection. One is the biophysical, in which the maternal uterine artery resistance, maternal history, and the mean arterial blood pressure is another important, and biochemical is the placental growth factors or PLG. So if combined all these things, definitely the prediction rate is increased and we can make out which patient is the high risk. So if we analyze these factors one by one, if we take the maternal demography, the detection rate is 53% in less than 34 weeks of preeclampsia and 45% in less than 37 weeks. In this demography, age, weight, racial, these all comes into the maternal demography. If we go for the mean arterial pressure between 11 to 13 weeks, again, it is important, mean arterial pressure is significantly better than the systolic blood pressure or diastolic pressure alone for predicting the preeclampsia, especially in the first trimester. But important thing is that it should be measured properly. The device should be validated. Method should be proper after taking 5 minutes rest on both arms. Arm should be supported. Cup should be of the normal size of the according to patient, and it should be taken in both arms and the mean to be taken. So by this we can avoid the error by in the measuring the blood pressure. The error can be occur in from 6 to 50 millimeter of mercury, depending upon the criteria is not completely fulfilled. So we have to use the correct method. When we combine with this maternal factor with the mean arterial pressure, the detection rate is increased up to the 65% in less than 34 weeks and 60% in less than 37 weeks. Next come to the mean arterial pulsatile index. has been taken average of the left and right side, and 95th percentile of mean percentile index. If you use abdominal ultrasound, it is 2.3, and transvaginal 3.1. So it alone detects 48% in early and 26% in late preeclampsia. When it is combined with this, then with the notching, then the detection rate is increased up to the 50%. So this, by combining the uterine pulsatile index with the maternal factor and mean arterial pressure, the detection rate is increased up to the 80% in less than 34 weeks and 70% in less than 37 weeks of preeclampsia. So next is the PLGF factor. The PLGF is synthesized by the placenta and has potent angiogenic function. As in the beginning I told, there is this balance between the angiogenic function factor and anti-angiogenic factor. So this is the angiogenic factor, and if we use alone, if the value is low, shows the marker of shows the abnormal placentation. So if we use this marker alone, the detection rate is 55% and 33%. But it is better than the other biomarkers. So when we combine with this, the total, when it increases the detection rate up to the 90% in less than 34 weeks of preeclampsia and 75% in the less than 37 weeks pregnancy. About the PAPS-A, this PAPS-A screening, that does not improve the performance of first trimester screening, so it does not included as a marker here. So what is the next? How it is helpful, these marker, how it can be helpful? So there is a the detection rate has been, there is a software which detects the high risk. If you feed these values, it detects the high risk, and by this we can make out which patient is on high risk and which patient is of low risk by calculating the risk stratification. If the risk stratification is less than 1 in 100, definitely we can see this patient is of low risk, but if it is more than 1, then it is included into the high risk. So in the high risk patient, we have to go for the maternal history, prior risk, biophysical markers, and biochemical markers. These are the useful in case of high risk cases. So this is the flow chart which shows how we can manage the patient. If she comes into the low risk, we can leave the patient for routine prenatal antenatal checkup, and if she is high risk, then we have to add something as a prophylactic measurement. So for prophylaxis, we can use aspirin. The aspirin trial shows if we start aspirin in the first trimester before placentation, definitely it would be helpful. So in less than 37 weeks, it decreases the preeclampsia by 62%, and in less than 34 weeks pregnancy, it decreases up to the 82%. So we can start aspirin as a prophylaxis in case of when there is a high risk factor. So, but it should be started early at 11 to 13 weeks, and those should be in adequate amount, 150 milligram per day. Why? Because 75 to 80 milligram, which we use as a routine, there is a chances of developing resistance in 1/3 of the cases. So when it is required, it should be used in a proper dose and given in the night for the maximum benefit, and should be stop at 36 weeks, because these patients can go into labor anytime after 36 weeks. So it should be stopped, or if it should be stopped whenever we feel the patient is going into labor. Calcium, we can add calcium also. Even we are reading our residency also, 1.5 to 2 gram calcium can be added, and it should be started in the early pregnancy, through the early pregnancy. So what when the patient comes in the mid pregnancy or late pregnancy, then what we can do? In this, we have to go for the screening in the second trimester. So for this screening, we can use risk factors depending upon the history, and we can also include the blood pressure, SFLT, and PLGF ratio and uterine artery. Because if we but only we can detect the can screen at the second trimester also, but we lose opportunity of using prophylactic aspirin because the patient has reached into the second trimester and the placentation is already done. So it is not, the aspirin would not be very helpful. So this is the when there is a disturbance of the ratio or gives a higher value, then these patients are very prone to develop preeclampsia. So we can make the ratio between the SFLT upon PLGF means the anti-angiogenic upon the angiogenic factors, and increased value is always shows the patient is prone for the preeclampsia. Once the patient comes in the late gestation, then because the so many things which is already not able to make out, so what we should do in that, this ratio will help triaging the patient, because we by this we can make out the which patient is going to develop. So in 99.3% the negative predictive value, once this value is negative, at least we can be free mentally if this patient is not going to develop preeclampsia in next week, means we can, and if the patient is reaching already 37 or more, she can go into the labor anytime. But if this value is more, then we should be more conscious about the patient. So by this, we can make out if the value is less than 38, whether the pregnancy is 20 to 34 weeks or 34 to the delivery, the preeclampsia would be ruled out. But if it is more than 85%, even between 20 to 34 weeks, there is a possibility of preeclampsia. So we should be very careful. And if it is more than 110 in advanced pregnancy, again, there is a possibility of developing preeclampsia. So this is according to NICE guideline. So this ratio is very important. Even in the single reading, if there is a severely elevated ratio more than 655 between 20 to 34 weeks, we have to terminate the pregnancy because patient can go into eclampsia, preeclampsia or eclampsia. So by this we can counsel the patient, we can keep watch on the patient depending upon her obstetric history and how much the baby is essential for her. So for this is the ideal test and should be advocated to everyone. But is it possible? No, it is not possible in poor resource setting. It is good for the resource rich setting, but it is not like in our country when there's a loss of population, resource constraint settings. Yes, so for that the FIGO has recommended, this recommendation is very good, which is given by FIGO 2019. The recommendation that are rigid and impractical in real life settings are unlikely to be implemented, hence may produce little or no impact. Means this sophisticated, investigative facility is cannot be given to every woman, especially in our country. On the other hand, pragmatic but less than ideal recommendation may produce significant impact due to more widespread implementation. So we follow this guideline. So in this, when constraint setting, pragmatic recommendation is given in the as like routine screening for preterm preeclampsia, the maternal factors and mean arterial pressure is the best, and this PLGF and uterine artery pulsatile index should be kept for the high risk only, high risk group only. And similarly, if we add other factors, biochemical markers, again, it should be kept for the high risk cases. But the blood pressure should be done in every woman because it does not cause much cost, and mean arterial pressure and and family history definitely give lots of clue. So in India, whether we have for sophisticated facility, when there is a primary center, there is no facility, even there is no road also to reach to the patient, or even there is no facility to monitor monitoring equipment, even the education is care, delayed first antenatal visit, and even some places there is no BP apparatus also to measure, and the patient does not come for the regular antenatal checkup more than 4 times. In that situation, these are the problem. The especially busy OPD, even in our hospital, we have 500 patients per day. So in this condition, definitely the loss of constraint occur. So lack of awareness, even in the periphery, there is no lack of awareness in the health worker, inadequate history taking by the health worker. Even sometimes there is no BP apparatus is present, or if they are present available, they are not measuring it properly. And there is a confusion also of starting the aspirin and dose of the aspirin. So these are the key barrier which comes in our day-to-day practice. If we calculate the cost of this sophisticated investigation like Doppler, biomarkers, the budget goes in crores. So in that situation, whether we can start aspirin to every woman, again, there is a big question, because we cannot start aspirin to every woman because it is associated with increased postpartum bleeding, postpartum hematoma, neonatal intracranial hemorrhage. So in this situation, we have to identify the high risk population, and the aspirin should be given only to the high risk patient, not as a routine to every woman. So quantification of the risk is very important, and with that we can make out the, for that in our SDP gestosis score has been developed by our own people and by own FOGSI members. It has no cost involvement. It's easy for all health workers. So it has scored into 1, 2, 3. So if the score is high, we have to take, and this scoring is done by the careful history and assessment of the woman, a total score of 10 time to time. So in this, they have given score 1, 2, 3, depending on, and according to mild risk, moderate risk, and severe risk. So this is useful for our country, and this app is developed, that is SDP gestosis score developed, and by this we can do the scoring and we can advise and counsel the patient. So our aim to catch the patient early by triple test is the ideal and best, but contingency screening is optimum. Maternal factor with the mean arterial pressure is helpful in the minimum where required areas. So we have to predict the woman. These are the new tool which is under the research. So we'll have a far greater impact on PE outcomes than making more advanced testing technology and protocols available. These are the necessities, because only making protocol we cannot do. We have to create more awareness. We have to detect the case as early as possible. Even we can start prophylactic management in the early. So come to the take-home message. The pre-eclampsia screening should be offered universally to every woman, because we don't know which woman is going to develop pre-eclampsia. And according to Fetal Medicine Foundation, this multimodal screening is the best option, but definitely if it is available, should be offered in high risk cases. And for screening, we have to use combined test, which is more cost effective, and ultimately our aim to get the healthier pregnancies and healthier babies by pre-eclampsia detecting early in pregnancy, act early, screen early, and make the pre-eclampsia relics of the past. Thank you. Thank you so much.
I can see Dr. Manju Shukla ma'am is here. Ma'am, can please give concluding remarks and expert comments?
Expert comment. Shama, you have so clearly defined everything that I have no words to explain.
Thank you,
Everything,
Manjuji. Thank
how
you
to
so much.
predict, how to prevent. The most important thing is how to prevent. That is the thing you have to take precaution about. But to know that this patient is going to develop preeclampsia is little difficult for general PHC and district hospitals, where there is lot of rush and they don't take BP correctly.
So I have mentioned these things is a concern in our country, but we have to work on it, because still today we are receiving 3, 4, 5 patients per day as we are working in the tertiary center. So we have to, main thing is we have to make aware up to the periphery, even our health worker. As Dr. Madhuri Patel, she's saying we have to include in this our nurses also, because health worker and nurses would be very beneficial in.
Actually, in PHCs and other centers, only health workers are there who monitor the patient, who manage the patient, and they are the caretaker there. So, how to take BP, this is very important thing and very nicely presented. The ultrasound and color Doppler and all are very important, as you said. And reading of this umbilical artery and
Doppler,
notch,
notch, that is also important.
It is very important and very difficult to read by many. Many private practitioners, they don't know how to read. है नहीं?
तो मुझे तो लगता है आज की तारीख में हमारी जो हम लोग को बचपन से पढ़ाया गया है कि हिस्ट्री टेकिंग और क्लिनिकल एग्जामिनेशन, वो चीज वो आज भी काम आ रही है. Although we have lots of sophisticated tools, but still our clinical experience, there's no match with that. I can say
aspirin has come long way and it is very good also. But your presentation, you have taken every point very clearly. Thank you so much.
Thank you, Manju ji. Thank you. आप सभी को मेरे thank you so much.
Thank you, ma'am. Thank you, SP Jaiswar ma'am, for this wonderful talk and explaining everything in such a simple and effective manner. Our next very most awaited session, that is a talk on managing severe preeclampsia by Dean of Sikkim Manipal University, Dr. Muralidhar V. Pai sir. And to chair the session, we have most respected Dr. Manju Verma ma'am, Professor Dr. Manju Verma ma'am. We all know her and she's teacher of teachers. She has been past president UP chapter of Obstetrics and Gynae. मैम हमेशा मैम से हम लोग आशीर्वाद लेते रहते हैं और हमेशा चाहते हैं कि उनका हाथ हमारे ऊपर बना रहे. वेलकम मैम. एंड आवर नेक्स्ट चेयरपर्सन इज Secretary of Lucknow OBGYN Society, Dr. Nidhi Johari. She is Associate Professor at Saraswati Medical College, Lucknow. And she has been Vice President APGL Lucknow. And she has been also Treasurer of Lucknow Obs and Gynae Society. Welcome, Dr. Nidhi. I would request Dr. Nidhi to kindly introduce our speaker, Dr. Muralidhar Pai. Over to Dr. Nidhi, please.
Thank you so much, Amita. And I thank the whole ISOPARB team, Prayagraj, and for making me a part of this session and making me chair the session of such an important part of all of us, which is by no other than Professor Dr. Muralidharan B. Pai, who is Dean Sikkim Manipal Institute of Medical Sciences, Professor of OBGYN, Professor and HOD OBG KMC Manipal 2016 to 2021. He has been at MMC Malaysia 2000 to 2007. Sir is the founder chairman, Karnataka College of OBGYN. He has stated many positions in FOGSI, ICOG, and CEFOG. He has almost 694 guest lectures he has delivered. He has 201 publications. It is like showing torch to sun. It's so difficult to say anything about such giants of obs and gynae. And he has been awarded as 13 Best Teacher Awards, teaching materials, and 4 Best Research Awards. He has been the author of the 4th edition of Fallen and Bruised, which our textbook for obstetrics. He has been 35 years of teaching experience, 30 years of examining experience as MBBS examiner, MS, MCH, PhD, and everything. So, sir, we are so honored to have you on this session, and we hand over the mic and the screen to you for your expert talk.
Thank you very much, Dr. Ranjana Khanna ma'am, for inviting me to this prestigious webinar of ISOPARB Western UP, and respected Manju Verma ma'am and Dr. Nidhi. Thank you very much for the kind introduction and chairing the session. I bring greetings to you from SMIMS Sikkim and this beautiful place. I invite all of you to visit this place as well. So let me straight away jump into the topic, managing severe preeclampsia. I will also talk about how to handle a non-severe preeclampsia. There is nothing like mild, moderate, severe. It is straight away preeclampsia or a severe preeclampsia. What we have to clearly understand before handling a case of preeclampsia is that preeclampsia is not just about hypertension only. It's a multi-system and progressive disorder. It is entirely different from the hypertension that a non-pregnant lady or a man has. This has to be understood very clearly. That's why it is a different ball game altogether. The management of preeclampsia is almost like a balancing act between the maternal and the fetal health. 1 minute. Okay. So if you only think of mother, that is the best care for the mother may result in FGR. Whereas best care for the fetus may place the mother at risk. So this is probably the best or the typical example where obstetrician has to think of 2 lives at a time. Of course, every single decision in obstetrics is that only, but in preeclampsia, all the more we have to think of both of them and we have to give the best for both of them. Before going into the management proper, I need to clarify certain definitions. This is the latest ICOG practice bulletin, which was published in 2020, where an absolute figure of 140/90 is considered as gestational hypertension. However, traditionally, we have been telling that a rise of 30 systolic and 15 diastolic also justifies the treatment. And we still follow that particular thing in Manipal, because let us say the absolute blood pressure is less than 140/90. For example, it may be, let's say, 135/85. But we all know many ladies have got very low blood pressure in a normal situation, something like, let's say, 100/, let's say, 60 or 70. So there is an increase of 30 over a 15 diastolic, and that is dangerous trend. By waiting some more time, the BP may shoot up. So we should not wait till it becomes 140/90 is the thought behind it. However, if you want to strictly go by theoretical definition, it is 140/90. Now to this, in the past, we used to say a proteinuria of more than or equal to 300 milligrams per liter was enough to call it preeclampsia. But then we will be missing out on so many things. That's why now more things are added. This or platelets less than 10 to the power of 5 per microliter, or serum creatinine more than 1.1 milligram per DL, or doubled AST and ALT, or pulmonary edema, or headache, or visual symptoms. So any one of them, if it is present, it qualifies to be called preeclampsia, not just proteinuria. Because proteinuria may be part and parcel of the game, and even the severe proteinuria, what we used to call more than 3 grams %, is underplayed by this latest thinking. So if to all of them you add convulsions, it becomes eclampsia. So this is basic, but I thought I need to clarify this. Now, as I said, all of them in the backdrop of chronic hypertension becomes a superimposed eclampsia or preeclampsia. That completes the classification. But we need to know the difference between a mild to moderate preeclampsia, which is clubbed together, and a severe preeclampsia. What constitutes severe preeclampsia? In addition to all that I mentioned, what is most important is a persistently high blood pressure of 160 by 110 for more than 2 occasions, on more than 2 occasions, at least spread by 4 hours apart. So this is very, very important for us, because all the complications will increase steadily after these thresholds. So I come to the management now. Basically, it consists of 3 things. Number 1, control of hypertension by using hypertensives. Number 2, prevention of eclampsia by using anticonvulsives. In fact, every medical disorder in pregnancy has a central theme of preventing a complication. For example, in GDM, it is prevention of, let's say, ketoacidosis in mother and macrosomia in the baby. Whereas the central aim of management in case of a preeclampsia is to prevent eclampsia, because as Madam Jaiswar said, in spite of so much of research, we have not yet pinpointed the exact cause of preeclampsia. Until we do that, it is very difficult to prevent preeclampsia. We can only take certain precautions, but eclampsia at any cost should be prevented. We know preeclampsia is the cause of eclampsia. That's why we use anticonvulsives. And finally, whatever you do, as I said, it's a multi-system disorder. Unlike a chronic hypertension with which a person can live for years together, preeclampsia or eclampsia cannot be resolved or conquered unless you deliver them, because whole pathology lies in the placenta. It is placental origin, with all that Madam explained. So we have to finally deliver. But then the timing of delivery is the most important question. As I said in the earlier slide, the balancing act. If you deliver too early, then the baby may suffer. If you deliver too late, the mother may suffer. So in that interim period, we need to control the hypertension and prevent eclampsia by starting anticonvulsives. So let me take up one by one. First is controlling the hypertension. Now, there is a slight difference in managing the hypertension part in medicine proper and in OBG. That is why we need to know about this. Otherwise, the physicians will make not only fun of us, they may treat it wrongly. They may say these OBG people do not know how to manage a hypertension. That's okay, but they will manage the hypertension the way they want, or the way they manage the hypertension in a non-pregnant person. Our targets, that's why, are slightly different. We may not want to hit the bull's eye, because if you bring the blood pressure too low, then the baby will suffer. So that's why our targets are slightly different. What are the principles? The principles: when to start the antihypertensive, when to start it. That is the biggest question. That is the level of hypertension. Second one is how to treat it, meaning what should be used and what should be avoided. the favorite antihypertensives of a physician may be different from the favorite antihypertensives of an obstetrician. Let me first talk about the levels. When you say levels, as I said earlier, severe means 160 by 110. Moderate means 150 by 59, that is systolic, and 100 to 109 diastolic. This is only with respect to hypertension and not preeclampsia. I want to clarify that. And then mild means 140 by 140 to 150 in the systolic and 90 to 100 in the diastolic. If there are too many numbers here, we can simply say 110 diastolic, 100 diastolic, and 90 diastolic. These are important because, as we know, diastolic is more important as much as systolic in pregnancy. So among the three, the debate has been when it is mild and moderate, how to treat, but there is absolutely no doubt with respect to severe. In severe preeclampsia, it is always recommended to start an antihypertensive because it is believed to reduce the risk of maternal stroke. So whatever controversy was there, I'm using the word was because now it is much more clear with respect to treating mild to moderate preeclampsia. A prudent approach is better, which also considers patients' comorbidities and symptoms, that is headache, visual disturbances. What I mean by this is that you may say when the blood pressure is 90 diastolic, there is no need to start antihypertensives. In fact, we followed this particular principle for a long time, not only in Manipal, elsewhere in the world also. But then this sentence means just don't go by the diastolic blood pressure. You see whether the patient has got, in addition, headache and visual disturbances, because there have been reports that even with 90 diastolic, people have thrown convulsions. So we have to look at the scenario on the whole rather than just concentrating on the diastolic blood pressure. Then the benefits and potential risks of treatment are a little bit less clear. That's why we have to be all the more prudent. What were the concerns in the past? The concerns were aggressive lowering or medication themselves inhibit the fetal growth. That's what I said. If you too much lower the blood pressure, as it is, there is vasoconstriction and blood may not reach the fetus and fetus may have fetal growth retardation. And some of the drugs that can be harmful to the fetus. These were the concerns. So when to start, whether to start at 90 or should we wait till 100? In the past, till this particular CHIPS trial took place, we waited till the diastolic reached 100. We didn't start at 90 because even though 90 is the diagnostic point, the logic that time was that if you took the blood pressure below 90, then the fetus would suffer. Let us see what these articles said, especially the 2015 CHIPS trial, which came up with whether to start at 85 or whether to start at 100. So they found that maternal treatment did not increase the risk of FGR or causes excess fetal risk. So this gave us little more courage to start antihypertensives even at 90 diastolic, provided the patient has other comorbidities. I'm reiterating that fact again and again. Are there any benefits? Yes. Lower BP was associated with reduced occurrence of severe maternal hypertension during pregnancy, but it did not result in less preeclampsia or maternal stroke. There were benefits definitely, but it did not totally take away preeclampsia part because, as I said right in the beginning, preeclampsia is not equal to hypertension only. Hypertension is one of the manifestations of preeclampsia, which is a bigger disease. So overall safety, all antihypertensive drugs cross the placenta. That's what we have to remember very clearly before starting any hypertensives. There are no data from large, well-designed randomized trials on which to base a strong recommendation for use of one drug over another. But it is very, 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 very clear that these drugs should be avoided in pregnancy. This is where physicians make a mistake because they have a different favorite antihypertensive agent, and that is the one they will prescribe without properly updating themselves with these drugs are contraindicated in pregnancy. I'm not talking about all physicians, but most of them. Unless he is interested in also treating a case of pregnancy-related hypertension, they usually oversee this problem. They forget this. ACE inhibitors, they should be avoided at any cost. These are the favorites of physicians. So also ARBs and direct renin inhibitors, because they are associated with renal anomalies and FGR in the baby. So they are out. What about the mineralocorticoid receptor antagonist, that is spironolactone and eplerenone? They cross the placenta and never been proven safe in pregnancy, so they also should not be used. Now, what about thiazide diuretics? As such, diuretics should not be used to bring down the blood pressure, because in pregnancy, there is a situation of poverty amongst plenty. What it means is that there's plenty of fluid in the body. There's edema everywhere, water everywhere, but there is no drinking water. That's what we say in a flood situation. Similarly, there's plenty of fluid in the body, but fluid is in the wrong place. It is not in the intravascular compartment, it is in the extravascular compartment. And if you use diuretics, it will further drain that. However, after delivery, you can use diuretics to bring down the blood pressure. But during pregnancy, it should not be used. Only in very rare situations like pulmonary edema, it may be used. Generally, it is not used antenatally in preeclampsia unless there is pulmonary edema has developed. It is used postnatally, as I said, if hypertension persists to prevent eclampsia. What about nitroprusside? It has generally a limited clinical experience. Possibility of fetal cyanide poisoning is there. We have to keep this in mind. It may be a very good vasodilator, and that's why it may bring down the blood pressure nicely. But what happens is 0.5 to 10 microgram is the only admissible dose, that too as a last resort for urgent control of refractory severe hypertension. I'm stressing on each and every point, and its use should be limited to short period of time in an emergency situation. So all these points make it not the most favorite antihypertensive. Then what to use? Don't use this, don't use that, don't use this, don't use that. But what to use then? In emergency situation, labetalol is the first line of drug now. It has taken over everything else. What I studied during PG and then the early part of my career was different, but now this is the leader. 10 to 20 milligram IV stat, this has to be given. And 20 to 80 every 30 minutes, but a maximum of 300 milligrams in a day. But let me tell you, I have never reached 300 milligrams so far in any patient. They usually come under control. Or you can start an infusion after the initial 10 to 20 milligrams IV stat. You can start an infusion of 1 to 2 milligrams per minute. It has got fewer side effects. That's why it has emerged the most favorite antihypertensive, especially in emergency as well as otherwise. Only contraindication for this would be a case of asthma and heart disease. Other drug, of course, hydralazine is not a favorite drug in India, but when I was in Malaysia, this was their favorite drug. 5 milligrams IV or IM stat, 5 to 10 milligrams every 30 minutes, or infusion of 0.5 to 10 milligrams per hour, side effects being headache, fetal distress, and hypertension. This has been the most favorite drug ever since my PG days. Even now also it is nifedipine. The only thing is that it should be given oral. We used to give earlier sublingual, but sublingual can cause myocardial infarction. So I'm highlighting that it should be given oral, 10 to 20 milligrams oral stat, not sublingual. Repeat in 30 minutes if it is BP is not coming down, then 10 to 20 milligrams every 2 to 6 hours, but we have never used it more than 10 milligrams 3 or 4 times a day. Again, headache and tachycardia are its side effects. Now, after emergency, To maintain the blood pressure, it can be labetalol again, 200 to 2,400 milligrams per day. But as I said, we have hardly used it more than 100 milligrams 3 or 4 times a day. Nifedipine, 30 to 120 milligrams per day is written here, but we have hardly used 10 milligrams more than 3 times a day. Methyl dopa has been a time-tested drug, but now it is taking a very back seat because it takes a longer time to control the blood pressure after initial dosage. That means if you start today, the first effect will be seen after 24 to 48 hours. And nowadays, it is not the most favorite, though it has been there for time immemorial. 500 milligrams QID was the typical dosage, and the maximum also is that much only. Labetalol has both alpha and beta adrenergic blocking activity. It may preserve uteroplacental blood flow to a great extent, and it more rapid onset of action than methyl dopa is its advantage. And it has some hepatotoxicity. It may confuse with health. That has to be kept in mind. Slightly more adverse outcomes in RDS, sepsis, and seizure when treatment for chronic hypertension. Although less well studied in pregnant women, Pinodelol, and long-acting metoprolol are acceptable alternatives if you don't want to give labetalol. What about hydralazine? As I said, hypertensive response to hydralazine is less predictable. That's why it's not the favorite at all. It can also be taken orally. Again, 25 milligram tablets used to be available. We don't use it. However, it causes reflex tachycardia and fluid retention, which limits the usefulness in pregnancy. Nifedipine, safe, immediate release of oral nifedipine for acute hypertension, sustained release for long-acting nifedipine for maintenance, and sparse data on amlodipine, which is again the favorite of physicians. We don't use it because patient may develop edema and it will confuse the whole scenario. Verapamil and diltiazem is also can be used, but we don't have much data on that. Methyl dopa, as I said, widely used in the past. Long-term safety is established. Only a mild antihypertensive agent. It is slow in onset. That is its biggest disadvantage. Many will not achieve targets or bothered by sedative effect of it, and better outcome than labetalol on the whole, though. Clonidine, it is bothersome side effect. That's why we don't use it during the pregnancy at all. Possibly a rebound hypertension, if it is stopped suddenly, they all have to be tapered. But it is mostly preferred in postnatal period because methyl dopa has got some sort of depressive situation or symptoms. Nitroglycerin, as I said, an option if there is pulmonary edema in the rare occasion when IV diuretics are not effective. You can give it as a 5 microgram per minute, gradually increase to 3 to 5 minutes to a maximum of 100 microgram. What about bed rest? Of course, in preeclampsia, bed rest is okay. Otherwise, in most of the situations, bed rest is not a treatment anymore. It can be harmful. But does it help actually? It may improve uteroplacental blood flow, especially if the patient is lying down in the left lateral position, and it may prevent the exacerbation of the hypertension. However, there is no evidence that it significantly improves major maternal or fetal outcomes. It is not recommended in stable chronic hypertension. As I said, bed rest can sometimes give rise to DVT later in postnatal period. What about salt restriction? So much is talked about it. Normal diet without significant salt restriction is generally advised. That means she need not take additional salt or additional pickle, but whatever salt is already there in the food is okay. Salt restriction may induce low intravascular volume actually. We have to be careful about that. So she should take normal salt. Now I come back to our targets. I said our targets are different, but what is our target? Our targets are systolic 130 to 150. Don't go below than that because it will hamper the blood flow to the uterus. As far as diastolic, don't go below 80. 80 to 100 should be there because that's the one which gives actually blood to the baby at the periphery. This is regarding the target. The next one is how fast we should bring down the blood pressure, rapidity. Should we just throw it like a dart we throw? No. It is actually controversial because the cerebral or myocardial ischemia or infarction can be induced by aggressive antihypertensive therapy. So it has to be brought down slowly like that. 25% over 2 hours. Don't bring out drastically. There can be, that's exactly why we say don't give sublingual nifedipine. This is the third and last time I'm telling that. Second aspect of management is prevention of eclampsia by using anticonvulsives. When to use that? Whenever there are signs of imminent eclampsia, which means headache, blurring of vision, and pulmonary edema, exaggerated reflexes, elevated enzymes, both in the liver as well as in the creatinine. So the drug of choice, of course, is magnesium sulfate. It is proven beyond doubt. It's the cheapest of the drugs. That's why no company is interested in promoting this. Status epilepticus, of course, you have to use diazepam in addition to magnesium sulfate. But when you give neurology consultation finally, for a long-term use, magnesium sulfate is not going to be useful. Either you have to use phenytoin sodium or levetiracetam. So we prefer Zuspan regime in Manipal because we have that mission to deliver the exact dosages. At 0 hour, we give 4 gram IV, 20% solution slowly. This also doubles up as a neuroprophylaxis if the patient is less than 32 weeks gestation. That's the reason why we prefer this. And the amount of magnesium sulfate used is in a very nice way and a uniform way, and that very painful IM injections are avoided. It is followed by 1 to 2 grams per hour IV infusion. We use the machine for that. And we ensure that preteral reflexes are present and output is at least more than 100 ml in 4 hours. And respiration is more than 15 minutes per. This has to be monitored whenever you use magnesium sulfate. Pichard regime, the old one, 4 grams IV stat, followed by 10 gram IM. And every 4th hourly, 5 grams on either buttocks. Again, the same 3 things to be monitored. If there are repeat convulsions, as I said, diazepam is the best one to take care of that. 10 milligrams, but whenever you use injection diazepam, it has to be given very slow. Otherwise, you can kill the patient. If the patient keeps on throwing fit convulsions while on magnesium sulfate, this is the best choice. Then I come to the last part of the management, and the third and the most important part is early delivery, irrespective of gestational age in the event of complications. Here, you always err on the side of mother rather than the baby. Of course, both are important, but if you have to choose between one, it's the movie directors choose the baby because they can get the second heroine, but obstetrician has to choose the mother because the mother is very, very important. She can always have another pregnancy and another baby. So timing of delivery is very, very crucial. If it is after 34 weeks, you can simply deliver. There is nothing else to be done, not even steroids. Whereas if she is before that, that is 33, 6 by 7 weeks, steroids should be considered and delivered. But if she is less than 32 weeks, we must give neuroprophylaxis. Anyway, for severe preeclampsia, we would have started magnesium sulfate as it is. In fact, the neuroprophylaxis was thought of because of the preeclampsia treatment. They suddenly found the magnesium sulfate used to prevent eclampsia also helps in the development of neurons of the baby. That's why we have to thank preeclampsia treatment with magnesium sulfate. Decision is not based on proteinuria. In any case, not to wait beyond 37 completed weeks. So maternal indications are imminent eclampsia. I have already talked about that. Eclampsia, definitely you can't wait anymore. There's nothing like intercurrent eclampsia, which used to be given in old textbooks. Abruption, active management, no more waiting. HELP syndrome, yes, it's a part of imminent eclampsia anyway. Hepatorenal failure, independent of imminent eclampsia symptoms, and encephalopathy. There is no way you can wait beyond whenever these things happen. So fetal indications, I have made a rule. I have talked about this many times, Murli's rule of 5. That is severe IUGR wherein AC is less than 5th percentile, poor BPP, that means score less than 5, low AFI, amniotic fluid index less than 5, and any of the 5 abnormalities in the Doppler, that is decreased CPR ratio, absent endosolic flow, reversal of flow in umbilical artery, or MCA, AOI, and ductus venosus. So what is the mode of delivery? Of course, it depends upon the urgency to deliver. If you have to immediately deliver, cesarean may be the option if she is not in labor. If you can wait, you can induce the labor anyway. Fetal weight is an important issue. If it is less than 1,500 grams, it is preferable to do cesarean delivery. And if it is more, anyway, usually it won't be more. Presence of growth restriction. If it is severe IUGR, better to do section. Presence of CPD, of course, cesarean is the only choice. Probability of successful induction with early vaginal delivery. So whatever I have told, I put it in a different slide in a different way, is that cesarean is indicated when there is severely growth restricted fetus, early preterm that is less than 34 and 1,500 grams, fetus in distress, presence of CPD and malpresentations and malpositions, and poor Bishop score. In practice, wherever NICU facilities are available with good survival rates for very low birth weight babies, the tendency is towards cesarean delivery. Anesthesia, obviously spinal and epidural. Induction, of course, is not contraindicated, but you have to weigh the pros and cons. Favorable cervix, ARM and oxytocin is the best. Similar management plus certain extra things in complications like eclampsia, you have to give supportive therapy. In abruption, you have to treat DIC and renal failure. In case of HELLP syndrome, platelets and steroids to be considered. So is necessary. Postnatally, monitor BP closely. Suddenly it can come down. Accordingly, you have to taper the antihypertensives. If features of severe eclampsia are present, then continue antihypertensives. And if you have started magnesium sulfate at least 24 hours after delivery, you should continue that. Consider diuretics now that the baby is out. And yearly, these patients have to be followed up with BP, lipids, fasting blood sugar, and BMI because it's a part of dyslipidemia syndrome. Thank you very much for your patient listening, and I'll stop sharing here.
Manju Verma, ma'am, please give expert comments.
Thank you and congratulations, Dr. Muralidhar Bhai. Such a nicely fabricated, precise, targeted, decoratively delivered talk, and the most important thing is that it is not only the do's which are important, it is the don'ts also that are very, very important. So one must know what are the don'ts so that you don't commit mistakes and which we can regret later on. So I would like to simply say it was so nicely emphasized on all the points, drastic, how the definition has changed, how the things has to be monitored, and then to avoid a drastic fall. Everything you have covered so nicely. I must congratulate. It was a wonderful, wonderful talk by Dr. Muralidhar. And I would like to now in the end like to thank Ranjana and the whole ISOPARB team and the AOGS and the Lucknow team to have been arranging such a nice talk on a subject in which we lose the mothers, which is second to the hemorrhage. So this is one thing which we have to target now. So again, congratulations to all of you. Thank you very much.
Dr. Pai, I just want to say in one word that we were spellbound. Absolutely. Not for a second did I lose my eye contact with the slides or my interest. It was just fantastic. As usual, though.
Thank you.
Thank you, sir. It was such an enlightening lecture, and thank you, chairpersons. So moving towards our last session by our own President ISOPARB, Dr. Khanna ma'am, on fetal growth restrictions, preventive aspects, and obstetrical management. Since Dr. Ritu has been busy, I'm taking this session also. And to chair the session, we have very dear Dr. Lalita Shukla ma'am. She is right now President AOGS and Director of Arogya Niketan Hospital, Prayagraj. Welcome, ma'am. And our next chairperson is Dr. Vanna Bansal, ma'am. She's infertility and IVF specialist and advanced laparoscopic surgeon. And she's Director of Jeevan Jyoti Hospital. And she is doing high risk and infertility management since long. If Dr. Vanna Bansal is there, I would like to request her to kindly introduce our speaker, Dr. Khanna, ma'am.
Thank you. I'm Dr. Amita. At the first, I'd like to thank Dr. Ranjana for making me a part of this conference and like to congratulate her for such a wonderful topic and wonderful conference. So Ranjana Khanna is a well-known figure. First of all, I'd like to say that she is a very dear friend of me, and she is a very nice human being, and she is the pride of Allahabad, and of course the pride of Uttar Pradesh also. Everybody knows her. She was the National Vice President FOGSI 2017, Founder President Prayagraj Chapter of ISOPARB 2021 and 23. She is the ICOG Governing Council member, which is very, very prestigious post. She was the President IOGS 2013 to 2016, and she has ruled all the heart of the FOGSI in Allahabad. He was the honorary AOGS 2001 and 12, and treasurer 2008 to 10. She was the organizing chairperson of many very wonderful conferences like the Obstetric Dilemma and the BOH Trilogy and the Samana. And she is the faculty of various national and international conferences and webinar. And she is conducting so many. And she is the national awardee, FOGSI Smriti Malan Award, Save the Girl Child, AICOG 2013. And the FOGSI Dr. D.K. Tank Reproductive Healthcare Promotion Trophy also she has got. And she has been facilitated at various places. And her list is so long. And she has many articles and chapters in various books and journals.
Thank you so much, Vandana.
Excuse me, ma'am. Can I add just one word for you, Dr. Ranjana ji?
Anji.
You are just not for Allahabad. We are all so proud of you. You are from
for Allahabad, and
thank you.
Will be for India.
We are so proud. The whole of Uttar Pradesh. You are the daughter of Uttar Pradesh, not just Allahabad.
Yes, I agree.
We are so proud. You look so beautiful. You talk so nicely, sweetly. Oh my God! और जो कंटेंट होता है उस पे कैसे किसी का ध्यान जाएगा, मैम? ये बताइए.
Thank you so much, Nidhi.
She is in the heart of
Ranjana ji, I have always been admiring you, and the way you put up your things, the way you start your talk, the way you talk. Oh my God! And I used to think, हम लोग तो ठीक है, लड़कों का क्या होता होगा जवाब पढ़ाते.
This is the brain with beauty.
Yeah. Sweet.
मंजू जी क्या कहें, कुछ समझ नहीं आता. ये तो Thank you so much. I'm so sorry to interrupt.
Thank you so much, Nidhi, for boosting my morale. Thanks a lot.
No. Ma'am, I'm so sorry to interrupt, but actually I had to say this. I was like,
we are so proud of her being from Prayagraj, so she'll always say from Prayagraj.
नहीं, यूपी की है, हमने यही बोला, ये यूपी की है. प्रयागराज की थोड़ी है, यूपी की है.
हाँ, बिल्कुल, I agree. Okay, now I think I'll share my screen.
Yeah.
Good evening, everyone. My topic is one which we are facing on a day-to-day basis, fetal growth restriction. We'll talk about the preventive aspects and the obstetrical management. Fetal growth restriction is defined as a fetus estimated to weigh less than 10th percentile for gestational age. Small for gestational age is usually a neonatal term to define a birth weight of less than 10th percentile for gestational age. What is the pathophysiology? About 60% of fetal growth, this has been talked about by SP, is determined by genomic factors, 40% environmental factors. Epigenetic processes regulate the growth according to the environmental stimuli. Insulin growth factor 2 is the main hormonal modulator of embryonic growth. Principal influence on birth weight is by the placenta. In normal pregnancy, what happens is that the trophoblasts, they invade the spiral, endometrial and myometrial arteries, remodel them into widely dilated uteroplacental arteries, causing uteroplacental flow impedance to progressively decline and maternal blood flow into the intervillous space to increase exponentially. In FGR, this remodeling can be deficient, resulting in endothelial dysfunction, shallow placentation, fewer spiral arteries, increasing resistance, less nutrition, and hypoxia. These changes can lead to fetal growth restriction, preeclampsia, and spontaneous preterm birth, which may share some common pathophysiological mechanisms. Review of history and records of prior pregnancy is essential. Occurrence of FGR should be verified by review of dating criteria, gestational age at birth, birth weight percentile, management interventions, postnatal cause and risk factors. Hypertension is associated with 30 to 40% cases of FGR. This is a neonate born diagnosed as FGR. Causes of FGR in the mother: poor gestational weight gain, constitutionally small, poor nutrition, social deprivation, eating disorders, drugs and teratogens, infection, maternal medical conditions. In the fetus, there could be fetal malformations, genetic anomalies or multifetal gestation, placental or cord abnormalities. What are the risk factors for fetal growth restriction? First, we'll talk about the history-based risk factors. Maternal demographics: advanced age, underweight woman living in high altitude, severe anemia, hemoglobinopathies, environmental factors, medical conditions, chronic hypertension, CKD, SLE, APLA. Then we have diabetes, obstetrical history, previous pregnancy affected by FGR or preeclampsia, biochemical markers, low PIGF, low PAPA, high AFP. Ultrasound-based markers, we talked about this: uterine artery pulsatility index, more than 95th percentile, and bilateral notching, marginal or velamentous cord insertion. Now, when we talk about the fetal growth velocity and the growth charts, now fetal growth, the velocity can be detected once you plot the growth of the baby on these growth charts. They are the universal growth charts are there, but these are not correct for the Indian babies because our Indian babies are smaller than their Western counterparts. So what we need is the customized growth charts or the local and regional growth charts. On that, when we plot the growth of the baby, we can very easily come to know whether the fetus is getting growth restricted or not. What are the key recommendations? As MBBS students only, we are taught about the fundal height. So symphysis to the fundal height is a simple, inexpensive tool. That is the primary screening strategy for FGR, whether it's a low resource setting or a high resource setting, but in low risk pregnancies. Local or regional growth charts, we've talked about this. Criteria from Delphi consensus, including both biometric and functional parameters, should be used to define FGR. So this is the Delphi consensus criteria, but we won't go in detail. Confirming gestational age. Now, this is very important. Early ultrasound at less than 20 weeks is the best method to estimate the gestational age. Crown rump length measurement at approximately 8 to 13 weeks is the best method to estimate the gestational age, as in this picture. Then, how do we prevent FGR? In preconception visit, a healthy lifestyle modification should be stressed upon. Optimize any comorbidities if they are present. Optimize the BMI. Recommended gestational weight gain is 12.5 to 18 kg in underweight, 7 to 11.5 in overweight women. And we must counsel that short interpregnancy interval is associated with an increase in FGR by 40%, and the optimal interval should be 18 to 24 months. Smoking cessation should be stressed upon. Bed rest does not prevent low birth weight, has been associated with significant increase in preterm birth in certain populations. Nutrient supplementation prevention. Magnesium is the only micronutrient that might be associated with 30% decrease in FGR in low-risk women. Zinc supplementation did not reduce the incidence of FGR, but it's not clear whether those women were actually zinc deficient or not. Vitamin D supplementation was associated with the trend for benefit in prevention of FGR in a very small trial, but more research is needed. Then we have increased levels of oxidative stress markers and decreased levels of antioxidants in preeclamptic women. This suggests that oxidative stress markers play a significant role in the pathophysiology of preeclampsia. Supplementary dietary antioxidants may have a beneficial role in the prevention of preeclampsia in women at high risk for this condition. This has been a study which has been done by Dr. J.B. Sharma and Dr. Ashok Kumar. And they also studied the effect of lycopene on preeclampsia and IUGR, and they found that antioxidant lycopene reduces the development of preeclampsia and IUGR. Overall, there was 51.4% reduction in preeclampsia and 49.3% reduction in IUGR with the antioxidant lycopene. Mean diastolic blood pressure was significantly lower in the lycopene group. So preventing FGR, the medical interventions, aspirin. In women with high risk of PET, administration of aspirin 100 to, actually it's 150 milligram daily at night, at or before 16 weeks of gestation. Dr. Pai has talked about this very beautifully, and it reduced the risk of FGR by nearly half. LMWH, enoxaparin for preeclampsia and IUGR was studied in EPPI trial, but there was no difference in the rate of composite outcome. So LMWH does not have a role in preventing FGR according to the latest evidence, and its use in FGR is only limited to research settings. So how do we diagnose FGR? Accurate dating is essential and can be accomplished. We have talked about this in the first trimester. Ultrasound gives the best results. Owing to association of fetal anomalies, level 2 scan is also recommended, 18 to 22 weeks. Best ultrasound parameter for prediction of FGR after the first trimester is the abdominal circumference. Other important parameters are estimated fetal weight, ratio of head circumference to abdominal circumference to femur length, and the Doppler changes. Uterine artery Doppler studies have a 50 to 75% sensitivity for FGR in high-risk women, but only 20% sensitivity in low-risk women. Only studied intervention, as told again by Dr. Pai, has been low-dose aspirin, 150 milligrams. Management. Now, the management is based upon the pathophysiology that what is affected is the vascular malperfusion in the spiral arteries. So suboptimal remodeling of the uterine spiral arteries has led to pharmacological strategies that influence the uteroplacental vascular function through endothelial nitric oxide pathway and vasodilatation. But there is no strategy with established efficacy yet. Sildenafil. Early evaluations of sildenafil as therapeutic treatment showed promising results, but an international collaboration, STRIDER, RCTs of antenatal sildenafil citrate for FGR showed no benefit, and possibly there was a risk of neonatal pulmonary hypertension. Antioxidants like arginine. Arginine is unlikely to have those unwanted side effects like sildenafil exposure in Dutch STRIDER RCT, but recent cross-species meta-analysis has combined all the data and come to the conclusion that arginine and nitrogen carbamoyl glutamate supplementation improves the fetal growth in complicated pregnancies. Gene therapy, this is very promising, VEGF gene therapy, in which adenoviral vectors are introduced into the maternal uterine artery, and it increases the uterine blood flow and reduces the vascular contractility. This appears to be safe because neither the mother nor the fetus are affected, but more studies are required before we can introduce it into our clinical practice. Now, so in the end, we are left with one option, delivery. So is that the only option? Fetal growth restriction implies that fetus suffers most from poor nutritional exchange. Sustained starvation is rarely the cause. It is lack of oxygen supply to the fetus, resulting in chronic or acute hypoxia that leads to perinatal death. Only management that actually treats this placental insufficiency is delivery, which prevents stillbirth but predisposes to postnatal death from prematurity. So, as pointed out by Dr. Pai, the balancing act has to be there. Early onset FGR is rare. This extreme phenotype has significant individual impact owing to aggravated effects of prematurity, death, or survival with severe impairments. All severe morbidities are expressions of underdeveloped organ function. Lungs, We have RDS, bowels, necrotizing enterocolitis, immune system, sepsis, maybe meningitis, cerebral blood vessels, ICH. So what is the most important thing about the delivery is the timing of delivery. Timing of delivery is based on estimated balance of risk of ongoing intrauterine hypoxia versus the consequences of iatrogenic premature delivery. In pre-viable period, consideration of expectant management is warranted, even when you are expected that the fetal death could be there. But because delivery often confers near certainty of postnatal death, in scenarios, however, whereby severe fetal compromise is present before viability, pregnancy termination should be done, especially when the mother is at risk. Viability may occur at later gestational ages for fetuses with FGR, and determination of the moment of viability depends on the expertise of the obstetrician. So this is a Doppler chart, and this shows a proper systolic diastolic flow in the umbilical artery Doppler velocimetry studies. B shows absence of end diastolic flow, and C shows reversal of the end diastolic flow, which is an ominous sign, precedes fetal demise. CTG. Fetal heart rate is a function of autonomic nervous system. When hypoxia starts, FHR variability decreases, whereas progressive hypoxia causes spontaneous decelerations. When there are repeated decelerations unprovoked by uterine contractions, there is a strong consensus that imminent delivery is warranted because hypoxia is present and stillbirth can take place now. Importance of, however, low FHR variability is less clear. Short-term variation is a measurement of FHR variability by computer analysis, because often what happens that inter and intra-observer variability of visual CTG observation is very misleading. So this can give us an idea. Now we talk about the ductus venosus waveforms. This, if it is combined with CTG, it gives better outcomes. It is likely that intrauterine malnutrition and hypoxia affect some fetal organs before others. In early onset FGR, cardiac dysfunction can precede the cerebral dysfunction. Now, when we combine CTG and Doppler evaluation of DV as monitoring modalities to time the delivery, the optimum results are supposed to be better. These have been seen in the TRUFILL trial. Then biophysical profile is a crude composite score of combined assessment of the fetal movements, reactivity of CTG, and assessment of amniotic fluid. But association of abnormal BPS is not as good as the other parameters we've talked about, CTG and ductus venosus waveform studies. Late onset FGR, from diagnosis to delivery in late onset FGR, when the placental reserve is already challenged, interval between onset of nutritional deprivation and life-threatening hypoxia is typically shorter than in the early onset FGR. Now, what is important is that this concept is actually easy to manage but very difficult to diagnose. DigiTAT study, randomized women with fetuses suspected to have FGR at 37 weeks gestation to delivery or expectant management. So they either delivery at 37 weeks if the fetus has got FGR or expectant management. And they found basically not much difference, but they found in fact that more fetuses in the expectant management were in the lowest birth weight percentile group. And these were fetuses who were at risk of later developmental delay. This study shows that the selection of the fetus at risk is still imperfect, and the ideal approach is sadly still not known. Corticosteroids, benefit of single course of antenatal steroids to accelerate fetal lung maturation has been unequivocally established remote from term. We have to offer this potent preventive therapy as it is endorsed by all the professional societies. Findings from studies assessing magnesium sulfate for prevention of eclamptic seizures was reduction in the risk of cerebral palsy and several studies have confirmed that magnesium sulfate has neuroprotective effect and can reduce the incidence of cerebral palsy when given to women at risk of early preterm. Now we come to this flow chart. The patient comes to us before 34 weeks. So if it's less than 24 weeks, deliver if maternal status indicates, otherwise repeat ultrasound every 1 month. More than 24 weeks, less than 34 weeks, evaluate the maternal status and comorbidities, umbilical artery Doppler velocimetry, fetal testing by BPP, NST, consider steroids for lung maturation, consider delivery if reversed end diastolic flow, non-reassuring fetal tracing on CTG, or if maternal or obstetrical indications necessitate a delivery. If there are no indications for immediate delivery, begin antepartum fetal surveillance, regular fetal testing, weekly umbilical artery Doppler velocimetry, weekly evaluation of amniotic fluid. Now repeat sonography after every 1 month, 3 to 4 weeks. Now, if fetal growth continues, keep on taking the baby till 34 weeks. If there is no fetal growth, then consider delivery. Now, if the baby is more than 34 weeks but less than 38 weeks, the management is practically the same as in the previous, but we have to try to take the baby then till 38 weeks and then deliver. Otherwise, if growth is not taking place on repeated ultrasonography, then we must consider delivery. So in the end, some clinical care points. We all know that the common mechanism in FGR is suboptimal remodeling of the uterine spiral arteries. Doppler ultrasound of the uterine artery, umbilical artery, and middle cerebral artery can be measured throughout pregnancy and provides an indication of placental function. And I think all of us are relying heavily on this. The main obstetrical decision for FGR remains timing of delivery. In early onset FGR, management hinges on weighing the risk of prematurity versus the risk of fetal hypoxia. In late onset, the clinical challenge is the correct diagnosis of the fetus at risk for hypoxia. Thank you.
Actually started with hypertensive disorders of pregnancy and culminated in IUGR. And I think there's a strong correlation between that and this. So it's very obvious that besides other causes of FGR, hypertensive disorders are one of the main causes. So whenever a patient comes to us, we have to rule out hypertensive disorders also. Another thing is key, the gestational age has to be determined. We think it's FGR, and at times the patient is telling us the wrong LMP. So the importance of age, as you have said before, 13 weeks is very important. We have to be very sure that what the patient is telling us and what the situation is, they correlate. Another thing is the importance of diagnosis of at the early age plus aspirin. It has been said repeatedly, even in hypertensive disorders as well as FGR. It has been stressed by all the speakers. And of course, early diagnosis and the proper treatment. We should not deliver a preterm baby and face the consequences, but we should not let the IUD also to happen. So Ranjana has clearly explained before, during, and after what we are supposed to do. And that was a very good talk, Ranjana. And thank you for including me in this session as a chairperson. And I really had, it was very nice. All the talks were very nice and very illuminating. Thank you.
Ranjana ji, can I ask you a question?
Yeah.
Ranjana ji, I have a patient. She has been a patient of PCOS from the very beginning, from the time she had menarche. Okay. And then I didn't see the patient. I saw the patient like, it is a practical issue, which I am asking you. So she didn't remember when she had her last menstruation. For her, it was like December somewhere.
Okay.
So, and usually also she never menstruates. She has to be given by some like periphery wale doctors say withdrawal deti hai to unka menstruation aata hai. So अब उसके बाद उन्होंने जब पहला अल्ट्रासाउंड कहीं कराया था मार्च में, so they said the endometrium is 12 millimeter and they couldn't see anything regarding the fetus or the gestational sac or yolk sac, anything.
Okay.
Right? And then it was in March. When in April mid she got it done, she ultrasound, she didn't menstruate also. From December, she didn't menstruate. So there was a baby which was like 7 to 8 weeks, which is itself very contradictory. And that's the issue with all of us. Because ऐसे बताते रहते हैं लोग. अच्छा, उसके बाद उन्होंने कहीं दिखाया तो उन्होंने पता चला कि उनके बच्चे का उन्होंने ये मार्कर कराया, मार्कर में न्यूक्ल फोल्ड गड़बड़ आया, तो फिर उनका एमनियोसेंटेसिस भी हुआ. आई एम टॉकिंग अबाउट अ प्राइमी. और मैम फिर उसके बाद जब उनका ये हो गया, एमनियोसेंटेसिस फिश हो गया, तो फिश में पता चला देयर इज नथिंग लाइक दिस, एंड शी कंटिन्यूड विद द प्रेगनेंसी. ही इज 32 इयर्स ओल्ड. अब उन्होंने जिससे अल्ट्रासाउंड कराया, जब अल्ट्रासाउंड एसजीपीजीआई में हुआ था, तो आई थिंक बिकॉज दैट इज व्हाट डॉक्टर जयस्वार वाज आल्सो टोल्ड अस, यू आल्सो नो, एंड वी ऑल नो कि जब भी हम लोग कॉलेजेस में होते हैं ना, तो बहुत रश होता है. And then we are really not very specific कि खट से उतना डेट लिख दिया, जेस्टेशनल एज लिख दिया. तो जो अल्ट्रासाउंड वहां पे भी किया गया, एसजीपीजीआई में हुआ था इनका फिश, उसमें भी उन्होंने जेस्टेशनल एज जुलाई में लिख दिया, 17 हफ्ते, बाय एलएमपी आल्सो एंड बाय अल्ट्रासाउंड आल्सो.
Okay.
Now she came to me because somebody told her कि ऐसा है कि अपन नवंबर में हम सीजर कर देते हैं, 12 नवंबर एलएम ईडीडी.
अच्छा.
And now it is a very tough point with me because then because अगर मान लीजिए नहीं होता है, we all know, हम लोग फर्स्ट अल्ट्रासाउंड से तय कर लेते हैं ईडीडी, फिर नहीं तो एसजीपीजीआई इज अ बिग इंस्टीट्यूट, लेकिन वो तो कॉरेस्पॉन्ड ही नहीं कर रहा ना. वो तो कह रहा है एलएमपी और ये डेट ऑफ एलएमपी एंड डेट ऑफ जेस्टेशन इज कोऑर्डिनेटिंग. उन्होंने दोनों को दिसंबर लिखा दिया.
अच्छा.
वो गलती उनसे हो गई.
नहीं, I think निधि, maybe that first ultrasound was not correct.
हाँ, तो मैम अब क्या करा जाए? बिकॉज अब बच्चा जो है वो नॉर्मली ग्रो कर रहा है. अभी लास्ट जो अल्ट्रासाउंड हमने कराया अपने लेवल पे, डॉपलर कराया, सब कुछ कराया, तो अब द अल्ट्रासोनोलॉजिस्ट वेरी वेरी रिनाउंड, आई एम नॉट नेमिंग बट यू आल्सो नो लखनऊ में सबसे रिनाउंड कौन है, उससे अल्ट्रासाउंड कराया, तो भी अब वो भी मतलब एवरीबडी कम्स इनटू दैट प्रेशर ना, कि अगर उसने कहा है इसमें करो, उसने कहा है इसमें करो, उसने कहा है इसमें करो. अब 4-6 लोगों ने बता दिया, एंड व्हाट टू डू नाउ फॉर अ क्लिनिशियन, इट इज अ ग्रेट प्रॉब्लम.
So now what is the report?
तो उनका बात माने तो बच्चा 4 हफ्ते से भी ज्यादा पीछे रह गया, एफजीआर, फीटल ग्रोथ रिटार्ड कर गया.
ओके.
बच्चे का वजन आज है लाइक टुडे इज 5th of November. I saw her tomorrow, yesterday also, और उसके पहले का जो अल्ट्रासाउंड है उसमें बच्चे का वजन बहुत कम था, 1.9 था.
ओके.
Maturity was like you also know.
नहीं, तो what is the EDD according to the ultrasound now, the color Doppler?
डॉपलर के हिसाब से मैम वो कह रहे हैं ये बच्चा दिसंबर फर्स्ट वीक में होना चाहिए.
I think you go by and what about SGPGI अप्रैल में हुआ था ना वहाँ?
मैम वो तो गलती समझ आ गई ना हमें. उन्होंने कह दिया जेस्टेशनल एज बाय एलएमपी एंड जेस्टेशनल एज बाय अल्ट्रासाउंड, दोनों को उन्होंने सेम ही कंसिडर कर दिया. वो तो दिसंबर कर दिया उन्होंने. दिसंबर के हिसाब से तो बच्चा पैदा हो जाना चाहिए था.
अब तो हो ही जाना चाहिए था.
हाँ. So now as clinicians, now you are also facing all these problems. So that is why I put up this question with you कि मैम ये हम private practitioners अब क्या बताएं, क्या कहें उनसे?
One with 8 weeks should be more accurate, I think. They cannot make a mistake of 8 weeks.
7 to 8 weeks wala, I think. You take that 7 to 8 weeks wala
as
the
April wala liye मैम.
As the landmark, you take that early ultrasound only.
और मैम हमने डेक्सा कवर तो कर दिया है. But do you think that we should take out the baby like 16 or 17th of November or should we not?
Ma'am wants to say something. बोलिए दीदी मंजू दी.
Now, first thing is that the ultrasound which says that 7 to 8 weeks should be taken as the correct thing.
Correct one, as the
irrespective of what SGPG or what anybody says.
Exactly.
So according to 7 to 8 weeks from April, now how many weeks is there if it is corresponding?
नहीं मार्च में हुआ था अप्रैल में.
If we take
April में हुआ है ना. 7 to 8 weeks was in April.
7 to 8 weeks, then the baby has to be delivered by 12th or 14th of November. But the baby is still 1.9.
That could be FGR.
How
that
much is the
could be
BPD?
FGR.
Now, look at, we that don't go in for by weight. We should go in for by parameters, other parameters. What is the femur length? Because femur length is the last to be affected.
Yes.
So go in for the femur length. If the femur length tells you that
it is coming December first week.
So I think it doesn't make any difference if you go in for that. Till the Doppler studies, till the venous flow is normal.
All right, ma'am. Doppler study is absolutely all right. Placental maturation is also all right. And femur length is saying that you deliver the baby in the first week of December.
Well, how much is
the right thing? Okay. And I think you can go. Only thing is that you have to monitor her very, very
carefully.
That's the only thing that you have to see her maybe twice a week.
Stalwart हो कि इस पेशेंट को हम कैसे हैंडल करें?
Twice a week.
अरे इसको वो दे दो ना MGD3 दे दो ना. MGD3 दे दो और वो एक preparation you give arginine and
मैम वो दे दिया. Arginine दे दिया. Complamina चला दिया. Or dextran.
MGD3 gives a Nidhi. MGD3 is giving very good response. It will increase.
कितने दिन में मैम measurable हो जाएगा?
I think you check it after again week 10 days.
Week में पता चल जाएगा?
हाँ, I think पता चल जाना चाहिए.
अगर हम MGD3 दें,
हाँ,
MGD3 में दे दें
और
एक
अर्जिनिन दे दो भाई. अर्जिनिन देना.
अर्जिनिन कैरी दे चुके हैं.
मैम अर्जिनिन चल रहा है. अर्जिनिन चल रहा है.
अर्जिनिन चल रहा है.
हम सिल्डाफिल की भी सोच रहे थे.
You can try,
but I have not because it is like asymmetrical IUGR and we really don't know which ultrasound is correct and which is not correct.
How much is the BPD? How much is the BPD?
BPD is corresponding to mid-November. That's the issue. अब मैडम किसको डिराई करें ये बहुत बड़ा मुश्किल है और वो लोग बिग पीपल हैं. बिग पीपल का मतलब ये नहीं होता है बिग पीपल. बिग पीपल का मतलब है कि बेचारे
अरे 9.4 है कि 9.9 है कितना है ये बताओ.
9 नहीं हुआ. 9 हो रहा है.
9 हो रहा है ना.
I think
you symmetrical IUGR है. Symmetrical IUGR है.
I think Nidhi, you wait for another.
IUGR, there has to be some other pathology. So you have to only monitor by the fetal movement count and by the color Doppler every third day.
Every fifth 5 to 7 days is all right also.
और
में भी मतलब अब नवंबर चल रहा है ना इसलिए इसको और फ्रीक्वेंट करना पड़ेगा. बस और कोई बात नहीं है.
मैम हम इन्हीं सारे पेशेंट्स के लिए आप लोगों से रिक्वेस्ट करते हैं कि आप लोग ये सब बताया करो कि क्या हम लोग ब्लैंकेट कवर दें. अब हमने लास्ट मोमेंट में पेशेंट देखा है, हम पेशेंट डिलीवर जल्दी कर दें वो भी एक बहुत बड़ा इश्यू हो जाएगा.
नहीं फिर हाइड्रोजेनिक प्रीमैच्योरिटी Nico के charges.
Madam, that is why I have put up this question because that patient otherwise has to be sectioned.
Yes.
हाँ, अगर हम सेक्शन नहीं करते हैं बाई चांस कोई दिक्कत होती है then it comes to my head कि
Of course,
you have to do a plant cesarean. You have to do a plant cesarean in this patient. You cannot let up deliver vaginally.
बिल्कुल.
I'm not.
And NICU facilities
not thinking at all. We are planning for a normal delivery. But the point is, what is to be told to the patient? The counseling of the patient. Arginine start कर दिया, Complamina start कर दिया, Dextran 40 के लिए भी उसको बोला और सोच रहे थे कि क्या करें. फिर हमने अपने यहाँ के सब लोगों से पूछा क्या अब एस्पिरिन का तो अब कोई रोल ही नहीं रहेगा.
नहीं तो शुरू में नहीं दिया. शुरू में नहीं दिया एस्पिरिन.
तो एस्पिरिन का भी मैम कोई रोल ही नहीं रह गया.
नहीं शुरू में तो बहुत अच्छा रिस्पॉन्स
अब नहीं दे सकते. अब नहीं दे सकते.
बहुत अच्छा रिस्पॉन्स आता है मैडम कि हम बता नहीं सकते. एक्सीलेंट रिस्पॉन्स आता है लेकिन अब क्या करें ये समझ नहीं आ रहा है, पेशेंट को कब डिलीवर करें. वी कैन वेट फॉर 1 more week डूइंग वो भी
I think you should wait.
Do it round about 20th of November because that will be by any way she'll be
So
37
I will
weeks.
come back to you, Manju ji also and Ranjana ji also. That what happened? क्योंकि तब तक हम सोचते हैं कि अगर बच्चे का वजन 8.9 था तो थोड़ा बढ़ ही जाएगा, क्योंकि यहाँ पे सर से कराया था तो सर ने बोला कि निधि अभी रुक जाओ 12-14 तक. अब उनको 4 लोगों ने बोला है, SGPGI ने बोल दिया 12 नवंबर को बच्चा आ जाए और ये हो जाए वो हो जाए. सो आई वाज जस्ट थिंकिंग कि ऐसा तो नहीं है, लग भी नहीं रहा है, IUGR भी लग रहा है, और देखने से मैम क्लिनिकली द पेशेंट इज रोबस्ट, बट द जेस्टेशनल एज जो है मैडम 28 से 30 हफ्ते के ऊपर आई नहीं है. और जब से हमने आर्जिनिन शुरू किया है 3 सेंटीमीटर उसके एब्डोमिनल डेप्थ बढ़ी है.
AFI कितना है?
AFI नॉर्मल लिखा उन्होंने.
और बीपी कितना है? बीपी ठीक है?
नॉर्मल, एवरीथिंग इज नॉर्मल. बीपी नॉर्मल, यूरिन में कोई एल्ब्यूमिन नहीं है, शुगर नहीं है, पेशेंट इज नॉट हाइपरटेंसिव, कोई दवाई नहीं चली उसको, आयरन कैल्शियम खाती रही अपना, कहीं पेरिफेरी में दिखाती रही, वहीं पे अल्ट्रासाउंड हुए 2-3. अब हमारे पास किसी ने भेज दिया कि नहीं जाओ, पहले SGPGI में कराया था, फिर मंदाकिनी जी लोगों ने बोला हो गया, जिसने भी बोला then they came to me. और अब ये सिचुएशन है, और AFI होता, कुछ गड़बड़ होता तब तो तुरंत निकालने का
एक चीज बताओ, तुम्हारे हिसाब से
कि भाई
वो
बच्चे में पानी कम है.
मिड दिसंबर में डिलीवर करनी चाहिए थी तुम्हारे हिसाब से.
हमारे
जो भी
हिसाब
है.
से नहीं,
नहीं जो
सर
भी है
के हिसाब से दिसंबर 1st week और 7 or 8.
So if you do
हाँ,
it by
तो ठीक
15
है.
weeks, 37
हाँ,
कंप्लीट हो रहा है, निको फैसिलिटीज
37
के साथ कर
वीक्स
दो,
में कर लो,
15 में कर
37
दो,
वीक्स पे
कोई
कर लो.
दिक्कत नहीं. 15th of November
हाँ हाँ,
कर सकते हो आराम
37
से.
वीक्स पे कर लो आराम से.
टू यू मैम, 15 को हम उसको काउंसिल करके कहते हैं.
हाँ,
बट मैडम ये सब जो हम लोगों के प्रैक्टिकल डायलेमास होते हैं, आप लोग इतने स्टालवर्ड्स हो, यू
तो
ऑल शुड
एक
लाइक
अल्ट्रासाउंड कहीं और से भी करा लो.
मैडम कहाँ से कराएं, सर से
मैम
करा लिया.
अल्ट्रासाउंड वाले
नहीं देखिए, वो बात अपनी जगह है.
ultrasound people also they put the onus on you in the end.
हाँ,
There's one
yes,
thing.
that
Yes.
is what's
As
happening.
far as amniotic fluid growth, they put it on you for you to
Yeah.
decide. And then it becomes a very big
हमें
problem.
अगर
What are you to decide?
उसका
They always put it on you,
उसका
especially in
फंडल
such
हाइट
cases.
लगातार 28 से 30 मिल रहा है, हम कैसे कह दें कि इसका AFI नॉर्मल होगा, लेकिन अब वो नॉर्मल लिख रहे हैं तो नॉर्मल है. क्योंकि मैम ये है, जितना भी आपका ट्रस्टेड पेशेंट हो, हम अगर कुछ भी बताते हैं क्लिनिकली कि भाई ठीक है 30 हफ्ते के बराबर, अगर 30 हफ्ते के ऊपर उसका बच्चा मैंने देखा नहीं मैम, 3 सेंटीमीटर मैं आपको बता रही हूँ ना, आर्जिनिन शुरू करने के बाद मैंने उसकी एब्डोमिनल गर्थ भी नप पाई, दैट इज 3 सेंटीमीटर, इट हैज इंक्रीज्ड इन 10 days. और अब हम क्या करें, क्योंकि बच्चा 30 हफ्ते का ऊपर, हमें फंडल हाइट 30 हफ्ते मिल रही है. अब वो कह रहे हैं AFI
but
ठीक है.
I am telling you one thing, तुम MGD3 स्टार्ट करो मेरे कहने से.
हाँ, थोड़ा
करते हैं
वेट
मैम.
करो फिर तो. हाँ.
क्या डोज में दे मैम MGD3?
once daily.
Once a day.
कोई साइड इफेक्ट तो
day.
नहीं आएगा?
No, nothing.
Very safe.
It's very safe and very effective.
So thank you so much ma'am, and I will come back to you, और हम आपको मैसेज डालेंगे जब वो डिलीवर करेंगे.
पक्का.
Good, very good. We would like to know.
Thank you so much ma'am, thank you for taking so much of your time. Thank you so much ma'am. Thank you.
2 kg बच्चा will survive, don't worry. 2 kg baby will
हमारा
survive.
पति
आराम से.
न्यूनेटोलॉजिस्ट है मैम, बच्चा तो वो बचा ही लेगा,
वही
लेकिन
मैं
हमें भी
कहती
तो
हूँ,
पता होना चाहिए कि
निक्कू
हम
है
अगले
तो
मरीज में क्या करें.
करेंगे.
हाँ,
वो बात नहीं है, बात तो मेरा आदमी न्यूनेटोलॉजिस्ट है, हमारा नीकू है, हमारा पीकू है, हमारे पास सब है, वो बच्चा तो बचेगा ही, लेकिन हमको भी पता होना चाहिए कि हम कहाँ गलत हैं, और हमें क्या और ऐड करना चाहिए. हम लोग इतनी बातें करते हैं, इतने सेमिनार्स करते हैं, सब कुछ करते हैं, बट वी शुड नो प्रैक्टिकली कि अगर ये मरीज कहीं बाहर से अल्ट्रासाउंड करा के पहला आ जाता है, तो हम कैसे उस फर्स्ट अल्ट्रासाउंड में कैसे हम अपनी EDD डिपेंड कर सकते हैं.
निधि, अब इसको एक काम करना, when she delivered, then you have all the parameters, and I think you should come out with it on the platform. कि this was the thing and this has happened. So this is basically a disadvantage of multidisciplinary approach to a patient.
नहीं, पर अब MGD3 तुम दे दो, MGD3 देना शुरू कर
अभी
दो.
फोन करके उनको बोलती हूँ MGD3 वो स्टार्ट करें.
बिल्कुल.
और मैं आपको रिवर्ट बैक करूंगी आप लोगों को, एंड थैंक यू सो मच फॉर योर एक्सपर्ट ओपिनियन. थैंक यू सो मच.
थोड़ा लेफ्ट लेटरल लिटाओ.
वो लेफ्ट लैटरल लेट के हाथ से आ गई है। जिस दिन से मेरे पास आई है कहती मैडम आप देखती, कहती बाईं करवट से लेटो, बाईं करवट से उठो। मैडम कितना बाईं करवट लेटे? अरे मैडम ये सब
अच्छा, प्लेसेंटा का ग्रेड क्या है भाई?
ग्रेड 2।
अरे यार कुछ गड़बड़ है,
कुछ गड़बड़ है। I think it's premature rather than
ये बात हमको बार लग रही, क्योंकि प्लेसेंटा अगर मैच्योर्ड ही नहीं है तो कैसे बच्चा निकाले?
अभी कैल्सिफिकेशन है नहीं प्लेसेंटा में। अभी चुपचाप रुको थोड़ा।
हमारा बच्चा निकालने का मन ही नहीं कर रहा है। ग्रेड 2 ग्रेड 3 में कौन बच्चा निकालता है?
कौन बच्चा निकाले यार? बिल्कुल
ना।
हमें जवाब भी तो देना अपने आप को पड़ेगा सबसे पहले कि हमने क्यों किया ये। बच्चा बच जाएगा, पेशेंट ठीक रहेगा, everything will be perfect. But still we should know in our heart that we have done correctly. We have managed the patient rightly. With you all around, आप लोग सबके होते हुए हम लोग के पास इतनी सारी अच्छी ओपिनियंस हैं, करेक्ट ओपिनियंस हैं। अगर ऐसा कुछ हम लोग करेंगे तो वो बात ठीक नहीं है। That is what I think.
Of course.
And I will get back to you.
Sure.
Thank you so much, ma'am. Thank you so much.
Amita, you are muted, Amita. Amita, you are muted.
Thank you so much, ma'am.
बस अब खत्म कर रहे हैं मैम, बस 2 मिनट। अमिता खत्म कर।
Since I can't see any questions in the question bank, so Dr. Pai है क्या? मैम Dr. Pai है क्या मैम? Yeah, मैम I have one question, but 2 मिनट में पूछ लेती हूँ। Ma'am, since we are getting so many patients with IVF और बहुत जल्दी मतलब eclampsia, मतलब mild eclampsia और even मतलब 14-16 weeks पे severe preeclampsia, मतलब BP का level 160/100/110, very precious pregnancy. So what are your opinion about मतलब single drug ही use करनी चाहिए कि 2 drug भी use कर सकते हैं?
अरे 2 ड्रग यूज करनी पड़ती है ना। आई यूज
करनी पड़ती है, लेकिन कभी जब आप लेक्चर्स में कभी ये बात नहीं आती है।
लेबिट्रोल एंड निफेडिपिन।
लेबिट्रोल जब फेल करता है तब नेक्स्ट।
हाँ फेल किया पारुल में तो फेल किया। अब सेकंड प्रेगनेंसी में वी डिडंट ट्राई लेबिट्रोल, वी जस्ट वेंट स्ट्रेट टू निफेडिपिन।
तो आप केवल कि दोनों?
नहीं पहली बार तो दोनों
एकदम स्ट्रेट अवे दोनों कैसे?
नहीं पहली बार दोनों, पहली बार तो डेस्परेशन में थे ना।
एंड जैसे कि आपने लेबिट्रोल दिया पहले, आप हमेशा यूजुअली मतलब एक्सेसिव बीपी होता है तो 100 मिलीग्राम टीडीएस पे स्टार्ट करते हैं, उसके बाद उसको मान लीजिए क्यूआईडी भी कर दिया, अभी भी नहीं बढ़ रहा है तो 200 मिलीग्राम टीडीएस की फिर आपने कार्डिया ऐड करना है, क्या करना है? मतलब नॉर्मली
निफेडिपिन यू शुड ऐड।
हाँ, कभी भी लेक्चर से होते हैं तो ये बात नहीं आती है।
You can start calcium channel blockers.
हाँ, nifedipine is good. अच्छा, there is a question in the chat box and that person is going on saying that my question I posted.
कहाँ है?
Question and answers में है अमिता?
नहीं, मुझे नहीं दिख रहा।
अच्छा, I'll read it out.
मैम 2 questions हैं भाई।
हाँ
2 हैं।
अच्छा मैम, मुझे नहीं दिख रहा है मेरे पास, शायद मैं मोबाइल से जुड़ी हूँ इसलिए।
एक ने लिखा है सर प्लीज रिपीट न्यूरोप्रोटेक्टिव डोज ऑफ मैग्नीशियम सल्फेट।
सेम आईवी डोजेस होती है।
है क्या डॉक्टर पाइस दे?
नहीं लग रहा देना।
नो मैम।
नहीं ना?
नहीं, सेम डोजेस होती है।
सेम डोजेस तो होती है। And then the next question is, ma'am, I had a primary 29 weeks gestational age with IUGR absent diastolic flow, oligo 7 centimeters, then abnormal NST, so it was terminated. She had adherent placenta, MRP done. HPR of placenta showed infarction and calcification. What should be done in her next conception? Aspirin to begin with?
Yes.
In the next pregnancy, to be very careful and start aspirin very early on.
Yes.
Before placentation.
Before conception, it can be started.
Yes.
Before conception or before placentation, you start early on. So then you won't have these problems, and that should be the best approach.
And yeah, she can test for Apla syndrome also. इतनी जल्दी क्यों IUGR and PET हुआ?
हाँ, investigation
तो करना ही पड़ेगा।
But
parvovirus infection has to be seen if early IUGR is there, that infection has to be ruled out.
And preventive measures, he's written that I advised for APLA. Yes. And preventive measures, you must start aspirin even before she conceives.
Yep.
For parvovirus, which test, ma'am? He's asking.
What?
Parvovirus. Hello? He's asking for parvovirus, which test?
वो तो लैब में से डायरेक्ट वैसे ही होता है पार्वोवायरस के लिए, वो है ही
अच्छा
टॉर्च में आ जाता है पूरा एक्सटेंडेड टॉर्च जो होता है उसमें आ जाता है.
Yeah, start aspirin and aspirin should be 150 milligrams, not 75.
Yes.
Okay, ma'am.
With this enriching scientific evening, the time has come to propose formal vote of thanks. First and foremost, my gratitude to our own AOGS and LOGS for holding our hands. My sincere thanks to ICOG office for granting us 3 ICOG points. And my heartfelt gratitude to our chief guest, Dr. Madhuri Patel ma'am, for her blessings and her support in our every endeavors. My sincere thanks to our chairpersons, Professor Dr. Manju Verma ma'am, Dr. Manju Shukla ma'am, Dr. Nidhi Johari, Dr. Lalita Shukla, Dr. Vandana Bansal, and Dr. Shubha Pandey for your active participation and valuable inputs. I am forever grateful to our speakers, Dr. S.P. Jaiswar ma'am, for her very clear messages, Dr. Mulidhar Pai sir, for her talks are always very welcome in our meeting. Thank you, sir. And our president, charming president, Dr. Khanna, for her brilliant talk. We are all enriched and going back with some clear take-home messages. My sincere thanks to Jagsonpal team, especially Dr. Deepika, for always supporting us and being there for us. Thank you so much. Last but not
least, above all, ICOG for granting us 3 ICOG points.
Our lovely delegates for making this evening a success. Thank you.
Thank you, Deepika.
I'd like to take you through a few of our products, which are L-arginine, lycopene, and DHA sachet of Lycorate Preg.
Yeah.
Then we have the Dydrogesterone as DIVATRONE 10 mg tablets and maintain Allistorenol 5 mg tablets.
Yeah.
So we look forward to your support to our products, maintain injection 250 and 500 mg also. Thank you all so very much.